So good morning everybody. I welcome you all for this session, and let's start with the first talk by Dr. Divya.
A very good morning to you all. Today I'll be presenting our findings of a short case series on visual outcomes of arcuate keratotomy in femtosecond laser assisted cataract surgery. As we all know, residual corneal astigmatism of 0.75 diopters or more induces symptomatic blur and other visual disturbances, and also reduces uncorrected distance visual acuity. Femtolaser assisted arcuate keratotomy has been shown to be a high precision, safe and reproducible method of decreasing postoperative astigmatism. However, the existing nomograms usually take into account only the anterior corneal astigmatism and may not always provide the complete correction. Commonly used nomograms we have the Donenfeld and Napa nomogram. The purpose of this study was to evaluate the astigmatic correction with intrastromal arcuate keratotomy in femtolaser assisted cataract surgery. It was a prospective interventional case series including patients with at least 0.5 diopters of corneal astigmatism but not exceeding 2.5 diopters. Patients with other ocular diseases compromising vision were excluded. Preoperatively, uncorrected and corrected distance visual acuity, keratometry, corneal tomography and biometry were recorded. And intraoperatively, the parameters of arcuate keratotomy and corneal incision were noted. Postoperatively, we recorded the uncorrected and corrected distance visual acuity and residual refractive error. And statistical analysis was done using SPSS2 software using mean, standard deviation and Spearman's correlation coefficient. Catalyst 1 was used to perform capsulorhexis nuclear fragmentation in arcuate keratotomy, which was intrastromal. Main port and side port incisions were usually made manually, but some were done with the same system. A 2.2 millimeter incision was made. The intrastromal incisions were of 80% corneal depth with 90-degree side cut angle, and an arc diameter of 8 millimeter or 9 millimeter were used variably. We used a modified variety of the Napa nomogram. 26 eyes of 22 patients were studied, and we obtained similar outcomes with intrastromal arcuate keratotomy in both the 8 millimeter and 9 millimeter zones, and with the rule, against the rule and oblique astigmatism, and in paired and non-paired arcuate keratotomy. Various arc lengths also gave comparable results, and arcuate keratotomy has generally been recommended for eyes up to 3 diopters of corneal astigmatism, and residual of 0.63 to 0.87 has been reported by various studies. We got slightly lesser residual because we had lesser number of eyes with higher degrees of astigmatism. However, we did not perform vector analysis and did not obtain the correction index, which is recommended in future studies. Lim et al. Also stated that single incisions and paired incisions give similar results. We also obtained similar results, but the number of single incisions we had in our study group was very small, so any conclusive evidence was not obtained regarding the same.
The time is up, only 3 minutes are there, already exited by 30 seconds. Please wind up.
Yes. Arcuate keratotomy thus can be seen to be an effective way of reducing lower degrees of corneal astigmatism using both paired and non-paired incisions. However, it was a small study sample with short follow-up duration, and there was lack of vector analysis. In future, these should be corrected, and a comparison between anterior penetrating and intrastromal arcuates should be done. Thank you.
Thank you, Dr. Divya. And the next speaker is Dr. Jitendra. Any questions for her? Divya, wait for a minute.
ये लाइट्स बंद करा के हॉल के चालू करा दो ना, हॉल के लाइट चालू करा नहीं, ये हॉल के हॉल से अपन चालू करो, कैमरा के लिए हम कर लेंगे, ये बंद करा दो.
What changes you had to get into the software to do this?
Sir, actually we didn't make any changes in the software. It was recommended from the people of the catalyst. They had come and they had decreased, they had just eliminated the anterior penetrating cut that was given.
Okay, thank you. So the next speaker is Dr. Jitendra Singh. Are you ready with the slides? Dr. Jitendra?
Yes, sir.
Yeah, go ahead.
Good morning, everyone. I will be presenting a poster podium on endocapsular ring implantation in subluxated cataract or modified technique. I directly jump to the what are the modification we did in for insertion of capsular endocapsular ring implantation. For insertion of capsular reservation modified technique, the CTR Unio ring is introduced through the main incision with the help of forceps so that the leading eyelet and the part of CTR inside the capsular bag. A second instrument, Sinski, was introduced through the anterior chamber through side port incision, which was kept over the part of CTR just outside the bag, gently pressing it. The second instrument guides the remaining trailing part of CTR Unio ring smoothly into the capsular bag as you push the ring with the forceps from outside the eye. What are the advantages? Firstly, it prevents the inadvertent escape of the endocapsular ring out of the bag in the sulcus. Secondly, it avoids any stress on the anterior capsule margin, thereby preventing tear or extension of the rhexis margin. Thirdly, it changes the vector force from vertically anterior-posterior to horizontally along the capsular bag, thereby reducing stress on existing intact zonules, preventing posterior dislocation of capsular bag CTR complex into the vitreous cavity. What is another modification we did for scleral fixation of Sioni ring? For scleral fixation, we first bent the straight needle of double arm times 0 polypropylene and made it a curved modification. That what we have achieved, it keeps the plane of the needle tip higher during its passage into the anterior chamber, preventing the damage to intraocular structure posteriorly, especially the capsular bag. Secondly, another modification made by us was to prevent capsular bag damage was use of a band 26 gauge needle to fetch the band curved needle of the 10-0 polypropylene suture outside the eye. Advantage of using band 26 gauge needle rather than a straight needle is that it keeps the direction of the tip upward during the passage through the scleral bed into the anterior chamber, so that the chances of the piercing and damaging capsular bag is very unlikely. Secondly, the feeding of the band curved 10-0 needle into the band curved 26 gauge needle become easier compared to straight needle as shown in the figure. To conclude, with the help of various endocapsular ring segment insertion and our modification, we could smoothly and safely implant the endocapsular ring in subluxated cataract with higher success rate, minimal intraoperative complication, and good postoperative outcome.
You think that the bent needle, its tip is intact, isn't it?
Yes, sir. We used to bend that 26 gauge needle as well as that 10-0 propylene, so that it is very easy. It is much better.
I'm just interested in knowing how often have you damaged the capsular bag with that bent needle. That's all.
With the straight needle, sir.
The one in which you
sir, we did, sir, 29 cases, and 3 cases. In three cases, there was enlargement of that rhexis margin or piercing with structures.
What could you have done to prevent it?
So, for preventing the rhexis margin, sir, then
anyway,
we
just inflate the bag with a good visco or Elon. Thank you.
Okay. Thank you, sir.
So next is Dr. Gayatri is ready. Dr. Soumya, Dr. Monica.
Dr. Gayatri is there?
Gayatri is there?
Gayatri Nair.
Dr. Soumya Sharma, please.
Good morning, everyone. I will be presenting poster podium presentation on a comparative study of 2.2 versus 2.8 mm incision at steep meridian in post-phacocorneal astigmatism. Cataract is one of the main cause of curable blindness worldwide, with the developing world accounting for approximately 3/4 of this type of blindness. With the advent of phacoemulsification and progressively decrease in size of surgical incision, cataract surgery has been changed into refractive surgery. Post-operative astigmatism remains an obstacle in eyes with significant pre-existing corneal astigmatism affecting post-operative uncorrected visual acuity. Corneal refractive changes following cataract surgery are related to the location and size of corneal incision. It has been proposed that by placing the incision on steep meridian, by marking the magnitude of pre-existing astigmatism, we can cause reduction in post-operative astigmatism. The reduction in incision size provides many advantages like reducing the need for suturing, leading to more wound stability and decrease in regular and irregular astigmatism. The study was conducted at SHRC Jaipur. It was a prospective randomized comparative study. The patients were divided into 2 groups depending upon the type of pre-existing astigmatism. That is, group 1 included 80 patients with steep vertical meridian, in which clear corneal incision at superior limbus was given either of 2.2 mm size, that is subgroup A, or 2.8 mm size, that is subgroup B. And in group 2 included 80 patients with steep horizontal meridian, in which clear corneal incision at temporal limbus was given either of 2.2 mm size, that is subgroup C, or 2.8 mm size, that is subgroup D. The steep axis was determined on the basis of preoperative keratometry. All the surgeries were performed by a single surgeon using a self-sealing triplanar clear corneal incision made on the steep axis using either 2.2 or 2.8 mm keratome, followed by routine phacoemulsification. Post-operative evaluation was done at 1 month, which included visual acuity, refraction, and keratometry. In group 1, the mean preoperative corneal astigmatism of subgroup A was 0.81 plus minus 0.33 diopter, which changed post-operatively to 0.24 plus minus 0.20 diopter. Whereas in subgroup B, mean preoperative corneal astigmatism was 0.75 plus minus 0.33 diopter, which changed post-operatively to 0.34 plus minus 0.30 diopter. In group 2, in subgroup C, the mean preoperative corneal astigmatism was 0.85 plus minus 0.33 diopter, which changed to 0.26 plus minus 0.27 diopter. And in subgroup D, the mean preoperative corneal astigmatism was 0.78 plus minus 0.32 diopter, which changed to 0.38 plus minus 0.29 diopter. In all the 4 subgroups, it was statistically significant with p-value less than 0.001. In group 1, the mean post-operative corneal astigmatism at 1 month in subgroup A was 0.24 plus minus 0.20 diopter, whereas in subgroup B was 0.34 plus minus 0.30 diopter. It was not statistically significant. In group 2, the mean post-operative corneal astigmatism in subgroup C was 0.26 plus
Why
minus.
Why not come to the conclusion, Soumya?
Please wind up.
Sir, in both groups 1 and 2, the change in preoperative and post-operative corneal astigmatism in all 4 subgroups was statistically significant, whereas there was no statistical significance in post-operative corneal astigmatism between 2.2 and 2.8 mm incision at both vertical and steep horizontal meridian.
Thank you. Soumya,
yes, sir.
So the astigmatism induced.
We say that we want the clear corneal incision on the steep axis so as to neutralize the pre-existing astigmatism.
Yes, sir.
And on the other hand, we say that we create 2.2, 2.8 triplanar incisions to reduce the astigmatism. How do you reconcile these 2 statements? We want to reduce the astigmatism. The only way is to achieve flattening at that meridian, isn't it? And we say that these incisions do not cause astigmatism. So how would you explain?
Sir, we are reducing the preoperative astigmatism first by giving a steep meridian incision according to the type of corneal astigmatism present preoperatively.
Okay, thank you.
Thank you, sir.
Dr. Monica?
Sir.
Okay, you can start. And next is Meghali. Dr. Meghali is there. Yeah,
Good morning, one and all. Today I'll be presenting on phacoemulsification, cataracts surgery in between 3D and conventional microscope, a comparison. It's not moving. Yeah. Over the past decade, many technological advances in machines, instruments, and IOLs has revolutionized cataract surgeries. And the 3D imaging system in ocular surgery is an exciting domain which is gradually being adopted by many surgeons. In the current study, we seek to document the experience and the comfort levels of operating surgeon with 3D heads-up technique with that of the conventional microscope and the challenges faced. It is a tertiary eye care, it was done at a tertiary eye care center in West India. All patients with senile cataract presenting to the cataract services between September 2020 to March 21 were included. And the sample size is 203 eyes with 80 eyes undergoing the 3D heads-up surgery. Surgeries were performed by 3 experienced surgeons having over an experience of 15 years with approximately 500 phacoemulsification surgeries being done in a year, with each of them having an experience of over 50 surgeries in the 3D platform. Patients with secondary complicated cataract or those who having any form of subluxation or any previous history of intraocular surgery were excluded. At baseline and each post-operative visit for 1 month, 1 week as well. The patients were assessed with BCVA, intraocular pressure, and fundus examination and anterior segment examination. Cognitive load assessment was done with the real tool times, which included SpO2 and heart rate. Intraoperative parameters were recorded throughout the surgery with pulse oximeter attached to the left toe. Post-operative findings were obtained after 10 minutes from the surgery, and baseline readings were taken 2 hours prior to the first surgery, and the first surgery of each day was only taken into the study. This is the self-report of the cognitive load was done by operating surgeon using the surgical task load index used by NASA questionnaire at the end of the surgery. Coming to the discussion, in 3D as well as in the conventional microscope group, the heart rate increased from baseline. However, from all throughout the steps, and distribution of the mean scores of the components of the task load index, such as mental work, physical demand, temporal task, and distraction, and total scores did not significantly differ. So the 3D viewing, the mean time of capsulorhexis was higher in the 3D group compared to the conventional microscope. So the 3D viewing systems gives advantages like good ergonomics, improved depth perception, lower illumination. Furthermore, it's an excellent tool for visualization and teaching. Has its own limitations of being expensive, learning curve, and latency and delaying of surgical view. So in conclusion, when compared to conventional microscope, performing surgery in the 3D platform does not hamper the surgical workload duration of the cataract surgery, but further studies are expected to these findings.
Dr. Monica, do you subscribe to the theory that the posterior capsular rent is always because of the surgeon factor, or there are some patient factors as well?
So there are a combination of surgeon and patient factors.
And which of these factors you could avoid with 3D?
So in our exclusion criteria, we had taken any, all the patient factors were taken into account to avoid that.
So 3D is a better system according to you, or what?
Sir,
to conclude, what is your conclusion?
The conclusion is that it is not inferior or like as so far with the limitation of a lower sample size, but it was not inferior even though if it was not superior.
Is it the future?
So we can say so that obviously comes with a with the factor of being expensive, but can be after a learning curve is taken care into account, it can be adapted quite soon.
Okay, thank you.
What do you think was the most advantage?
So for trainees, it was easier to understand how, like in certain steps, like how the hydrodissection planes were. It was more easily appreciable for teaching. And
I thought as far as your topic is concerned, the depth perception and the ability to keep the PC away from your aspiration port or any other instrument, because of that better depth perception is what should contribute to lessening the chance of a PC.
So far for the coming to the complications, we didn't come across any complications in either of the two groups.
I think it's a better teaching tool if you have students.
Yes.
Thank you. So we'll have a next speaker.
Thank you, sir.
Dr. Meghali, are you ready? Yeah. And
Good
after
morning.
Dr. Meghali is Yogika. Yogika is there, so be ready here. You can start, Dr. Meghali.
Good morning. Posterior polar cataract remains a challenge for every cataract surgeon because of the risk of a posterior capsular rupture. We would be discussing the strategies that we use to improve the safety and reduce the chances of PCR. We avoid overfilling the anterior chamber with viscoelastics. In young patients, high molecular cohesive OVDs may be used as scleral elasticity may contribute to anterior chamber shallowing. Size of the capsular recess more or equal to 5 mm is preferred to prevent backflow of fluid during hydrodelineation. Hydrodissection is contraindicated. Hydrodelineation is mandatory to separate the nucleus and the epinucleus. According to the Vasavada and Raj et al. Technique, one of the safest method is to make a trench, which is first sculpting, and then a right angle cannula is used to direct fluid perpendicular to the lens fiber in the desired plane through both the walls of the trench. It prevents inadvertent subcapsular injection of the fluid and overcome the difficulty of introducing the cannula to a significant depth in a dense cataract. There is a small video demonstrating the trench. Hydrodelineation, a right angle cannula is inserted through the lens matter at a particular depth, and fluid is injected to perform hydrodelineation. Once one of the trench wall is done, the other side is performed. Low parameters with a slow motion phaco is safest, power less than 60%, bottle height of 50 to 70, aspiration rate of 15 to 25 and vacuum of 30 to 90 is considered to be safe. During nucleotomy, care has to be taken to prevent collapse of the anterior chamber by judicious use of dispersive viscoelastic through the side ports before removing the phaco probe. Soft cataract can be removed by phaco aspiration, harder ones can be removed by phaco chop. Epinucleus removal done by IA, the thin layer of cortex adherent to the capsule is left behind. We leave the central area attached until the last stage of cortical aspiration done. The posterior layer and the plaque is dissected by viscoelastic and aspirated with the IA. Cortical aspiration should be done with a low bottle height. Pulling of the cortex is avoided. Tangential movements are safer. The posterior plaque should be removed at the last stage of the cortical aspiration, can be removed by viscodissection and viscopeeling and then aspirated with a phaco tip. This is a small video showing the viscodissection, lifting up the nucleus port. If in case of any doubt, we should look for the anterior vitreous which may reveal oil-like droplets and sharply defined round or oval white opacity, which may tell you that there is an absent or thin PC. The take-home message is to perform a good hydrodelineation with a cushion to protect the posterior capsule, adhering to the closed chamber technique, slow motion phaco for nuclear removal, followed by epinucleus removal by viscodissection. This can help in successful navigation of a potentially complicated situation. Thank you.
Break in. Did you employ any method to detect any pre-existing capsular dehiscence?
Pre-existing capsular rent, dehiscence.
Defect.
Couldn't get you, sir, sorry.
Pre-existing defect, can you identify by any test before surgery?
Sir, one is clinical by the slit lamp examination, which we have already mentioned. And second, sir, we have the facility of UBM. So that is how it is.
Thank you.
Thank you.
Thank you, sir.
Dr. Yogika.
Good morning, everyone. The topic for my podium presentation is comparison of a new monofocal and extended depth of focus intraocular lens after phacoemulsification. Nowadays, cataract surgery, it has become a refractive procedure rather than the visual rehabilitation because of improvement in the surgical techniques, including small incision and introduction of newer intraocular lens technologies. The extended depth of focus intraocular lens provides significantly, it increases the range of vision with minimal optical side effects of multifocality like halos and glares and aberrations. The extended depth of focus worked by creating a single elongated focal point to enhance the range of vision, that is from near to distance vision. They increase the depth of focus across a continuous range. This is the diagram showing the extended depth of focus. It has the optical diameter of 6 mm and a total overall diameter of 13 mm. It has an anterior aspheric surface and posterior achromatic diffractive surface. A newer generation of monofocal intraocular lens, that is Technis IONs, it was launched in October 2019 in India. This monofocal IOL, it designed in such a way that it extends depth of focus from distance to intermediate vision to meet the patient's expectations. The aim of my study was to measure and compare the visual acuities and the contrast sensitivity between these two lenses. This was a prospective comparative and interventional study, and it evaluated 31 patients after implantation of TechniScience 15 patients, and I used the suprafoveal EDOF lens in 16 patients. Exclusion criteria were irregular corneal astigmatism, corneal dystrophy, pupillary abnormalities, history of any glaucoma, intraocular inflammation, and for intraoperative or post-operative complications. The uncorrected and corrected distance, intermediate, and near visual acuities are measured at post-op day 1, first week, 4th week, and 3 months. And contrast sensitivity, they were measured at 3 months post-operatively. This is the slit lamp retroillumination photo at post-op day 1. On the right side, on the left side is the extended depth of focus lens, and the left side is the TechniScience. The TechniScience and suprafoveal EDOF group, they were comparable with respect to all the preoperative parameters. And both the groups, they shows similar distance and intermediate vision, but near vision was significantly better in the extended depth of focus as compared to TechniScience at 3 months post-operatively. The uncorrected near visual acuity is what was better in the EDOF group. The incidence of halos and glares were not seen in the TechniScience, but they were present in few patients in the extended depth of focus, but they were statistically insignificant. The comparison of logMAR uncorrected distance and intermediate visual acuities and corrected distance and intermediate visual acuities as post-op day 1, first week, 4th week, and 3 months, they were same at all the time durations. And the uncorrected near visual acuity, which was better in the EDOF group, it was highly statistically significant. The comparison of contrast sensitivity, patient satisfaction, and the incidence of halos and glares within the groups shows no statistical significant distance, but it was present in 2 patients in the EDOF group. The TechniScience and suprafoveal EDOF both were effective in improving the distance and intermediate vision, but near vision was significantly better in the EDOF group. Both groups retained good contrast sensitivity, and majority of patients they were satisfied. Thank you.
Had uniocular implantation or bilateral?
So in my study, they were uniocular. The patients, they were uniocularly implanted. Few patients for binocular implanted were not considered in the study. Thank you, sir.
Thank you.
Okay, thank you.
Dr. Alisha,
please.
Good morning, everyone. So topic for my poster podium is the efficacy of iris claw lens and scleral fixated lens in terms of deficient posterior capsular supporting patients. Introduction. Those conditions that can lead to aphakia can be corrected by anterior chamber IOLs, sulcus placement of IOLs, iris fixated lenses, and scleral fixated lenses. The aims of our study was to compare the efficacy of retropupillary iris claw lenses and sutureless gluteal scleral fixated lenses in terms of surgical time, intraoperative and postoperative complication, and visual outcomes. Material and methods. Our study basically a prospective, comparative, and interventional study, and includes 25 patients, those having deficient posterior capsular support. We divided randomly to total patients into 2 groups. Group A, that constitute 15 patients that underwent retropupillary iris claw lens implantation, and Group B, that constitute all about 10 patients underwent sutureless gluteal scleral fixated lenses. The inclusion criteria was that we included patients more than 18 years of age having inadequate posterior capsular support, and we excluded those patients with having a significant corneal pathology, significant retinal pathology, distorted anterior segment pathology, endothelial cell count less than 1000 cells per millimeter square. The technique in Group A was retropupillary iris claw implantation as conventionally done, and in Group B, extraocular 26 gauge bent needle guided intraocular haptic fixation was done. Observation and results. The basic etiology was 60% surgical aphakia in Group A, that constitute about 16% patients in Group A, and in 17% of Group B. While endothelial cell count was normally p-value was insignificantly different. Comparison of post-operative parameter. The mean surgical time in Group A was 22.55 plus minus 2.83, while in Group B 35.12 plus minus 2.64. The p-value was significantly p-value was statistically significant. The post-operative endothelial cell count was reduced in both the groups, but there is no significant intergroup difference was there. The mean IOP was there is no significant difference in both the post-operative IOPs. Low gamma BCVA was 0.34 plus minus 0.25 in group A, and in group B 0.39 plus minus 0.21. There is no intergroup difference was there in both the groups. Intraoperative and postoperative complication, mild iris bleed wall observed in 2 patients in group A, while mild iritis and ovalization of pupil was more frequent in group A. Such complication was not there in group A, but the slippage of haptics was observed in 4 patients of group B. Discussion, in our study most common etiology was surgical fistula in both the groups.
Why not come to the conclusion?
Both the techniques was adequately safe and with good visual outcomes. RPCIOL should be avoided in patients with inadequate iris supports. Likewise, SFIOL implantation should be done in caution with in patients of myopes. Surgical time can be a biasing factor for surgeon to choose between the 2 implantation techniques. Cost-wise, RPCIOL was available as less cost as compared to SFIOL. Learning curve for SFIOL is more steeper as compared to RPICLs. Thank you.
In your case series, how many patients were myopic?
Yes, sir.
How many patients were myopic?
Sir, only one.
Only one. And you told that the surgical time with SFIOL is more than iris claw lens, no? That was the only significant finding in your series.
Yeah.
So, considering the surgical time, which technique you will prefer?
So, obviously, iris claw.
Iris claw.
Yes, sir. It's lesser time taking.
Thank you.
Is the time is the factor or any other advantage with iris claw?
So technically for learning purpose is time taking of SFIOL obviously. Otherwise visual outcomes and everything is normal.
Thank you.
Yeah, next one. Dr. Siddhartha Dikshit.
Yes, I am here.
Yeah.
Should I start? Yeah. Very good morning to everyone. I wish the roads in Mumbai looked like what the hall looks like right now. Our study is a very simple yet unique study, and I will be covering this under these headings. We attempted to look at the time spent by a surgeon at each step of phacoemulsification. So each step meaning the time spent in the paracentesis, the time spent right from the beginning of the rhexis to the end of the rhexis, and that is what we have done and analyzed the differences between the expert and the trainee surgeons at our center within a defined study period. So experts were consultants who had experience of more than 500 surgeries, where the beginners were fellows and residents with experience of less than 50 surgeries for independently performed surgeries. All consecutive surgeries were taken for analysis. So this was unique because there has been no such study where one person looks at each and every step in phacoemulsification. There has been software which looks at particular steps, but this was unique in that aspect. We were happy to see that the visual acuity outcomes of beginners were also good, but definitely the visual acuity outcomes in experts were better. The total time, the time spent in each step was much lesser in the experts as compared to the beginners, which is no surprise. But what is surprising is when I show you these box plots. Now, if you look at this box plot, you can differentiate between the two by looking at this horizontal line, how far apart they are, the amount of overlap between the shaded squares and the whiskers that you see here. So quite clearly the rhexis time was lesser in experts. So was the total phacoemulsification time, the total time that was spent in irrigation aspiration. But what is very surprising, or not really surprising but never reported, is the time that the trainees spent not doing anything, looking at the eye, was the biggest difference between the two groups. Also was the difference that it was spent in exchanging time, exchanging instruments. This means that the entire training which we spend on doing these steps properly may not help in reducing surgical time. What is required is paying attention to the microscope handling, but through wet lab and simulators, clarity on the surgical steps, what is to be done next, and visualization on any expected, unexpected turns and asking for the next instrument. And of course, because other steps also are a big difference, continued improvement on the actual surgical steps. So a slight change in focus on training and you can reduce the surgical time quite drastically. Thank you.
Yeah, that was really a very nice presentation, but I just want to ask you, which step you think is the important for the residents, wherein they spend more time?
So
out of all the steps you have mentioned.
So the biggest difference lies in the inactive time. Unlike other steps of phacoemulsification, the time that is spent not doing anything, just watching the eye, is the biggest difference.
Okay.
But probably they are watching because the teacher is teaching them.
No, these are all independently performed surgeries. So basically, they probably just inject visco, start looking at the eye again, do a particular step in rhexis, or do half phacoemulsification, pull the probe out and start watching again, figuring out the thing. So that clarity on thinking what should they do probably is not there.
Do you think it was a structured learning? Is it a structured learning at LVPI? Meaning, first you learn this, after 50 things, 50 surgeries, you learn the next step. So then in that case, before starting the actual phacoemulsification, the time required by even these trainees would be less.
So these people have done 50 surgeries under observation, after which they are allowed to do independent surgeries. And though there is bound to be a difference, our aim was not to look at or criticize their lack of skills, but to understand where more teaching is required. And that understanding, I think, we gained from this study.
So how many students and how many teachers were compared?
Oh, sorry, there were 45 surgeries. The sample size calculation was 42, based on the previous studies, based on software analysis.
So 42 students?
42 different students, 42 different
consultants.
Based on your observations, what difference would you like to make in the training?
So we have already started doing this. So for our residents, we start showing them videos and ask them for an instant answer for what should you be doing next. So that is something that's very simple. So at a point when we sit with them and look at their videos and we see they're doing nothing, so we try to understand what is it that they have stopped for, and we have realized that it is just they feel a greater need to see the eye. That is understandable, but they've started improving once we have more discussions on these things.
More familiarity.
More familiarity.
Well, everyone has done smoothly. Surgery was uncomplicated at the hands of...
We did not take into consideration the surgeries which were complicated.
Okay. But extension of a study, if suppose a complication occurs, in that particular case, in which step that student or consultant has taken more time? Have you done that sort of analysis?
Yeah, that is something that will be very nice to do, but...
Kochi 2023.
Yeah, means then you can analyze that if you go wrong at that stage or you have taken more time maybe.
Comparison, possibly yes, the relative lack of complications in the expert group may be a factor which may come into.
And we presume that the grades of cataract were same and everything else was same.
Everything was same. These were all uncomplicated cataracts, 8 mm dilated NS2 to 3.
Same machine.
Same machine.
Same machine, everything. All other parameters same, only thing these two subsets.
Exactly.
Very nice concept and good way of learning also.
Thank you, Dr. Dixit. Astha Gandhi to present her work on surgical outcomes. Is she there? No.
She's not there.
Astha Gandhi.
Astha is now absent. Okay.
I think we can wait for Dr. Astha and who else is on there? Because and Dr. Gayatri, because we still have some time. Dr. Dixit, are you there? So in the meanwhile, we can have some discussion on the interesting topic.
Dr. Dixit, various methods are being practiced to train the residents for such surgical steps as such surgeries as phacoemulsification, vitrectomy, membrane peelings in vitreous surgery. Seeing videos is one thing, lacks the transfer of the cognitive skills, so to say. Simulators was a step ahead because it added some dimension to the cognitive skill development. But the main disadvantage ascribed to the surgical simulation was that though some amount of skill development is there, but the exact force and its replication in actual practice will differ. Which methods do you employ to train the residents, and which did you find the better, and would this observation change anything?
So I think I have a big advantage here in understanding how to teach people, because my own learning was very difficult. I had a very steep learning curve, and if I did not have the support of teachers that I had at CMC Vellore, I would have stopped doing surgery, in fact. So I think what really helped me greatly, and what has helped students significantly from the experience of the last 6 years of teaching that I have. Of course, you can also understand it much better than me with the experience that you have, and add to this, is visualization. So everything else will help, but what will really change the way I do surgery and make me be prepared for it, and this comes not only from teaching the students, but also when, say, we started performing gonioscopy-assisted transluminal trabeculotomies, we saw videos and started doing the surgeries, right? So in such situations, it's very important that you go sit alone, close your eyes after watching the videos, of course, and reading everything, and you start imagining yourself doing the surgery. So you should be able to see three things. One thing that you should be able to see is what is happening at the exact place where you want the action to happen. So if I'm imagining about GAT, I will see the MVR blade cutting the gonioscope, the trabecular meshwork. But at the same time, the second thing that you need to see is what is happening in the tissues around. Are there corneal folds? Is the AC collapsing? You need to keep an eye on that also. And the third thing you need to imagine is how is the hand moving? So if you can imagine these three things very clearly, then you can pick up deviations on the table very fast. So this is what I tell my students, and they find it useful. This is very abstract. This is very abstract, but I think this is a very significant component which can prepare you for situations, say for anterior vitrectomy. You cannot train someone while doing anterior vitrectomy that well. So if they can watch videos, talk to people, and then imagine themselves, that will help them prepare.
And then do yourself. You will learn more when you actually do.
Exactly.
You may watch hundreds of videos, but you will learn more when you are doing it.
You think this gap between seeing, assimilating, making a mental note, and actual doing, is this gap reduced by that surgical simulation?
Yes.
Oh yes,
yes,
oh yes. So we are fortunate to have support from a tech company which is called Help Me See, with an SICS simulator.
Yes.
So the rate of learning, though it's not been objectively studied,
very
we
difficult.
feel that the trainees are learning it significantly faster.
I think you have done a study, no? Those who have underwent simulator training, their performance after simulator training in LV Prasad.
Yeah, I was not aware that it has been published, that was going on.
No, it's not published, but the study is done in LV Prasad.
That's been going on.
Some trainees were trained on simulator and then asked to do surgery, and their performance was much better than those who were not exposed to simulators. So I think simulation training is the way forward, probably.
Absolutely.
Thank you, Dr. Dixit. I think we bring to the end of this session.
So now here we conclude the session.
Dr. Rajesh, Dr. Darshana, Dr. Santosh, and Dr. Viral Shah for their cooperation. Lovely presentations. All the best, dear friends. Thank you so much.
Thank you.